And I think on that note, we can go ahead and get started today. So again, my name is Rebecca Armstrong. I'm the manager of patient education programs at the Canadian Breast Cancer Network. And before we get started today, I'd like to cover a few housekeeping items. This session is being recorded and will be available on our website for anyone who may have missed it. I'll send out a link once the recording is available. You'll also find previously recorded webinars that address a variety of different breast cancer topics on our website. And if you haven't done so already, you can register for next week's session on side effect management for systemic therapies. We'll provide a link to the registration for that at the end of this webinar. I'd like to extend our sincere appreciation to our sponsors for today's session, who have provided support through unrestricted educational grants. Novartis, our gold level sponsor, Pfizer and Gilead, our silver level sponsors, and AstraZeneca, Merck, and Daiichi Sankyo, our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using our Q&A function that you should be able to find at the bottom of your screen. Our speaker today will do her best to answer any of your questions, but please note that she may not be able to speak specifically to individual situations without having a complete medical history. And I'd now like to welcome our host for today's session, Kathy Amendolia, the chair of the board for the Canadian Breast Cancer Network.
Thank you, Rebecca. And once again, welcome everyone. Thank you for joining us today. I'm pleased to welcome and introduce our expert speaker, Dr. Mita Manna, a medical oncologist at the Saskatoon Cancer Center and assistant professor within the Department of Oncology at the University of Saskatchewan. She is the provincial disease site lead for breast malignancies and nucleus member of the Real Alliance Breast Cancer Canada. Her research interests include quality improvement and real-world evidence. She is also actively involved in medical education. We are incredibly appreciative of all the time that Dr. Manna offers to the patient community by joining us today. Dr. Manna, great to see you, and thank you for being here with us today.
Wonderful. Thank you for that very kind introduction, Kathy. And thank you everyone for joining us today from all over the country. It's so nice to see we have people from spanning all the coasts as well as locally here in Saskatoon. So today I've been tasked with speaking on a very big topic on advancements in metastatic breast cancer. And I'd like just to start off by saying, a lot of people sometimes ask, what drew you to being an oncologist? What are some of the motivating factors that sort of keep you interested and engaged in the work that you do? And I'll have to say that, since my time practicing in oncology, the number of advancements in terms of therapies, supportive agents, clinical trials that we've seen come through the pipeline, the landscape has changed incredibly over just the recent years. So I'm pleased to try and condense this into this next hour and to give an overview to this. Once again, thank you to the Canadian Breast Cancer Network for inviting me here today. These are my other disclosures. So just some brief learning objectives. We'll go over the latest information about new and emerging treatments for all subtypes of breast cancer. We'll appreciate some of the insights from recent clinical trial data for all subtypes of breast cancer, and then also discuss the impact in terms of the Canadian landscape, as it might not always be readily available, and the access and availability for various medications might not be readily accessible in Canada. So I think it's important to recognize those nuances. I always think it's good to go back to the basics, to go back to understanding breast cancer epidemiology, the pathology, as well as staging. And I think it's always important to recognize that breast cancer still remains the #1 cancer in women, and to keep in mind that almost 30,000 women will be diagnosed with breast cancer each year. So it is a high number. And of course, today we'll be speaking mostly on stage 4 or metastatic. And I think it's also important to recognize that, this is a smaller subset of the population who are diagnosed with breast cancer, as a lot of the times we are speaking to our early stage 1, 2, or stage 3 breast cancer. But here we're going to be speaking to the metastatic stage 4. But before I get into that, I think it's also important to recognize that one of the most recent advancements and changes that have happened is the screening age for breast cancer, because this may impact outcomes, and we may be able to prevent further disease recurrences and relapses. We are noticing that more and more younger patients are being diagnosed with breast cancer under the age of 50. The U.S. task force changed the recommendation for breast screening to the age of 40. And the Canadian task force actually did not support that, but mentioned that those between the ages of 40 and 50 can discuss that with their family doctor, and this information should be accessible. Keeping that in mind, each individual province has actually modified their guidelines and recommendations. And so depending on which province you reside in, you may start to notice that the screening age has indeed been reduced to 40. I know that as of right now in Ontario, any woman over the age of 40 is able to receive screening. So definitely that is a big change in the world of breast cancer. Historically, we always classify breast cancer based on the receptor expression. And this was one of the very first, solid tumors where we started to use biomarkers to help drive treatment options as well as prognosis. So it's always important to recognize that we're always looking at the major subtypes, which would be our hormone receptor positive breast cancer, which happens in majority of the time, so about 70% of the time. And then you've got the HER2 positive patients that happen in about 20% of the time. And then, of course, when all 3 receptors are absent, then we're dealing with triple negative breast cancer. That has been sort of our historical classification when we're dealing with treatment and prognosis for patients. We will also touch on some of the new classification that has been discussed and incorporated in clinical trials. This is a very complicated slide here, but I think what's important to recognize is before we would sort of have a binary classification if someone was either HER2 positive or HER2 negative. But now we have more of a continuing or more of a spectrum where we're looking at identifying if a patient has HER2 low expression or something that's called HER2 ultra low expression. So I often describe it as, previously we would have the HER2 expression described almost like a light switch. It's either turned on or it's turned off. And now the HER2 expression is almost like a dimmer switch. It depends on sort of the degree of expression, whether it's HER2 low, HER2 ultra low, which will help guide what type of medications or therapies may be available. So that is something that has come about. So I'm going to break this talk into the subtypes that for clarity and to also discuss some of the novel therapies that have come about in each subtype. So first, I'm going to start with the biggest subtype that I described. So metastatic hormone receptor positive breast cancer. This will also encompass the HER2 low as well as the HER2 ultra low entities. The standard of care for hormone receptor positive breast cancer has really been established in the first line setting as a targeted agent, being a CDK4/6 inhibitor, as well as an endocrine therapy with an aromatase inhibitor. That has really been established as our standard of care first line therapy for patients who've been diagnosed with hormone receptor positive metastatic breast cancer. Having said that, beyond the first line, once patients progress, the optimal second line therapy after that really remains unclear. And really, there's a variety of different agents that one may select from, and there's no real set standard in terms of what may be better. And it depends on patient preference, what they may be eligible for, the disease itself, as well as some other entities as well. So really, it's almost dealer's choice in terms of what the second line option may be. And I think we're starting to get a bit of better understanding in terms of what these options may be. And this is when it comes into precision medicine or utilizing what's called next generation sequencing. And this, I think, is really highlighting the importance of recognizing that not all breast cancer cases behave the same, and that there are some of these minute entities whereby we may be able to utilize drug agents that can target specific mutations, and by targeting it, maybe we will have better outcomes. So next generation sequencing is essentially a way where we're able to test the DNA sequence in the laboratory to identify certain acquired mutations. And this has been established as something where we can do for our hormone receptor positive breast cancer cases. And we have studies and data to show that if we have certain mutations present, we have certain agents that we can utilize to target those mutations. What's happening right now is all of our pathology departments and laboratory departments across Canada are really keeping up to date and trying to ensure that they have the resources and adequate machines and panels available to provide this type of testing in a timely fashion for patients, and to also help oncologists determine their treatment pathway. So next generation sequencing is coming, and I think we'll start seeing it happening, being performed at each center. So what are some of these mutations or alterations that I'm talking about? Well, to break it down, we know that all of our cells in our body, and particularly cancer cells, have these complex pathways that essentially drive the cells to grow, proliferate, and divide. And one of these pathways that essentially affects the cell growth is called the AKT pathway. And essentially, it's almost like a domino effect, that if you have sort of a mutation in one of these pathway areas, it will essentially signal the cells to grow, divide, proliferate, which is essentially the mechanism of how cancer develops. So this pathway, the AKT pathway, involves mutations that could be involved in this PI3 kinase area here, this AKT area here, or mTOR. So essentially, these are like the dominoes. So if you have mutations in any of these areas, this can affect the cell and the growth. What's noted in the bullet point next to each of these purple blocks are essentially targeted agents that have been developed to essentially, if you have a mutation in any of these entities, if you use these agents that target those mutations, you can essentially try and stop or halt that cellular growth. So this is what I mean by precision medicine or targeted therapy. And so the Capitello 291 was a recent phase 3 study that looked specifically at one of these agents, looking at this agent capivasertib, which essentially binds to any alterations along that AKT pathway. And patients with metastatic hormone receptor positive breast cancer who progressed after their first line of therapy were randomized to receive this agent in addition to an endocrine therapy with fulvestrant versus placebo and fulvestrant. And essentially what we found was that there was improvement in progression-free survival, especially in those who had that AKT alteration. So as of right now, we do have availability where patients can get testing, companion testing performed, which is provided and supported at the moment by the pharmaceutical companies, and soon to be able to be done locally. And if patients are identified to have any of these mutations, we are then able to utilize capivasertib plus fulvestrant in these patients. Another very similar study was looking at another medication that targets that similar pathway, and that medication is called inavolisib. Same thing, it's looking at patients who have a mutation along that pathway where they're receiving inavolisib plus a CDK4/6 inhibitor, palbociclib plus fulvestrant, or placebo. But the difference in this study was this was not studied in patients who progressed after their first line therapy in the metastatic setting, but these are actually patients who who were receiving therapy for their early stage breast cancer, and they actually progressed while they were receiving endocrine therapy in the early stage or within 12 months of completion. So these are patients who are not presenting with de novo metastatic disease, but these are patients who had early stage disease and then relapse very soon, and then they receive this targeted agent. So this study has been presented, and we have data on this as well. As of right now, this is not currently something that we are able to access or something that's available in the Canadian platform, but I anticipate that in the coming months, this will be. Another very novel agent that we're starting to see not only in breast cancer or in hormone receptor positive breast cancer, but actually in all solid tumors across the board. These are medications that are called antibody drug conjugates. And antibody drug conjugates are essentially chemotherapy 2.0. They're essentially a little bit more of a fancier and more effective chemotherapy, where essentially they're a class of anti-cancer medications that specifically bind to a target, and they deliver this potent payload, which is actually chemotherapy. So if you look at this this pictograph here, you'll see this Y-shaped antibody, which essentially it binds to a specific receptor. And in this case, this antibody binds to a receptor called TROP2. And then these red dots that are attached to it is essentially the payload that essentially does all the work in terms of trying to kill off a cancer cell. So many of you may have heard of these agents called antibody drug conjugates, and they are definitely revolutionizing the landscape for breast cancer. When a patient is sitting in the treatment unit, when this medication is being infused, they're not able to tell the difference between that versus chemotherapy because it looks the same in the bag that's being hung, but it's a mechanism of action that's a little bit different. So these are not really terribly novel medications. These have been under development, in the past for the past 2 decades, and we've seen it sort of develop in the world first in hematology in lymphoma, for example. So some of the first agents came out to treat Hodgkin's lymphoma, and then we also started to see agents come out in HER2 positive breast cancer as well. And most recently, we're starting to see a very rapid development in terms of how these antibody drug conjugates are further optimized, where, the payloads might be stronger, or, the ratio to the linker to the payload might be better. So all of these differences and changes are being utilized to try and optimize these agents. In terms of the mechanism of action, as I mentioned, the way how it works is, first the antibody drug conjugate is infused intravenously. It binds to a specific receptor. The cell essentially consumes this antibody, and then essentially the payload is released within the cell to try and destroy the tumor cell. But sometimes a payload can also be released sort of in the surrounding environment and may cause sort of a bystander effect. Which is why it's important for us to not only understand the mechanism of action, but also the side effects that come with these agents. So one of the studies looking at antibody drug conjugates in the hormone receptor positive area was the TROPiCS-2 study, which is a phase 3 study looking at the use of sacituzumab govitecan, also known as Trodelvy, versus standard of care chemotherapy, so just single agent chemotherapy agents in metastatic hormone receptor positive breast cancer. And these patients are heavily pretreated. They may have received endocrine therapy, maybe at least 2 lines of chemotherapy before, and they were randomized to receive either this particular antibody drug conjugate versus chemotherapy. And we did see a benefit in outcome for these patients, and just similarly to the other agent, I anticipate that this will also be available in the Canadian platform in the near future. A very similar study was also performed, called a Destiny Breast 04. This is looking at a different antibody drug conjugate called trastuzumab deruxtecan, also known as TDXD versus looking at standard of care chemotherapy. Now, these patients were metastatic hormone receptor positive patients, but they were also looking at this new classification of patients called HER2 low. So these are patients that are not strongly HER2 positive, nor are they HER2 negative, but they essentially have a just a little bit of expression. So either immunohistochemistry expression of 1+ or 2+, as well as hormone receptor positive disease. A similar study which was recently presented at our big congress at ASCO last June, which is called the Destiny Breast 06. Same agent, trastuzumab deruxtecan. And this is also looking at hormone receptor positive breast cancer patients with HER2 low or HER2 ultra low. So these are patients where when the pathologist looks under the microscope, the expression has maybe a very faint speckle of expression there. And these are actually patients that were chemotherapy naive. So these are patients who have never seen any chemotherapy in the metastatic breast cancer setting. And with this study as well, we saw improvement in terms of progression-free survival. It's too early for overall survival. So we've now seen, 2 antibody drug conjugates showing benefit in the hormone receptor positive setting. One looked also at the HER2 low, and the other one also the HER2 ultra low. So I'm just going to delve a little bit into the HER2 expression just to elucidate some clarity in terms of what this all means. So what happens when we're looking at the receptor expression, the pathologist essentially stains the membrane of the tumor cell, and based on the strength of the staining will determine if it is HER2 positive or HER2 negative. But as I mentioned, now it's almost like a dimmer switch, where if it's somewhere in the middle, it's now what we call a HER2 low entity. So it's something that's a different classification to previous. There's also that HER2 ultra low entity, where if just a speckle is being expressed, essentially that is called HER2 ultra low. And I think it's important just to appreciate this is what the pathologist is looking at under the microscope. This is a strong expression of HER2 under the microscope, and this is a negative expression or a 0 expression. So that's essentially what I mean by the expression under the microscope. And the pathologists tell me that when they're looking at the HER2 positives, the 3+ expression here, they can almost tell it's positive just by looking at it with the naked eye before it's even put under the microscope. And, it is now becoming more challenging for the human eye to be able to detect, the difference between 0 and 1+. And I think this is where the advancements are going to come in the future in terms of how can maybe AI technology help our pathologists in terms of, discriminating between these minute differences, where essentially the initial test was really meant to determine that binary, is it positive or is it negative? But now we're looking at all these, differences right in the spectrum. And I think technology is going to help our pathology colleagues in terms of determining this expression, especially if it's going to help dictate which agents we can utilize. So this kind of transitions into HER2 positive breast cancer. And I mentioned this agent earlier for the hormone receptor positive entity, which was the trastuzumab deruxtecan, which is the HER2 directed antibody drug conjugate. And this one binds specifically to the HER2 receptor. And this really was the first antibody drug conjugate that really made some big headway in terms of the treatment of metastatic breast cancer. One of sort of our former antibody drug conjugates that we would use previously was an entity called trastuzumab emtansine, also known as TDM1. And I just want to highlight that, as I mentioned, that over the years, we're becoming these companies are becoming better at creating these agents where we see better benefits in terms of a higher drug to antibody ratio, so better efficacy. The linker that's actually binding to that payload, can that actually be cleaved off specifically? So we're seeing some improvements, in terms of these agents. It's almost like when we're looking at, even when you're looking at iPhones, for example, As you go through the generations, you're seeing improvements and updates, and everything's getting a little bit better each year. And that's how I look at some of these agents. You know, there's similarities to them, but you know, as the time goes along, they're just only getting better. And so, although this is not something, you know, novel or brand new, I think it's just important to recognize that the Destiny Breast 03 study was the first study that really, you know, shed light to the tremendous benefit of these antibody drug conjugates in the metastatic setting. And so these are patients with metastatic HER2 positive breast cancer that received trastuzumab deruxtecan versus TDM1, and they were previously treated patients. So once again, very heavily pre-treated. And, you know, this presentation did, of course, receive a standing ovation when it was presented at ESMO. And, you know, you see that the benefit here, that when you see these curves separate as substantially as they do, and the numbers where a hazard ratio is as low as it is and a very significant p-value, you know, it makes a lot of the clinicians very, very excited, because we know that this translates ultimately to better outcomes for our patients. And so this was really the first area where we're seeing true benefit for these agents. But we're here to talk about advancements, right? So that was the Destiny Breast 03, and that was studied in previously heavily treated patients. So we are now, once that, of course, shows benefit, we're now looking at studying TDXD, moving it up into the earlier line setting. So the Destiny Breast 09, which is ongoing at the moment, we don't have any results available as of yet, but that is looking at studying TDXD with or without some of our other standard agents in the first line setting in HER2 positive metastatic breast cancer. And I think that this, once again, if this shows benefit, will translate to better outcomes for our patients. And my center here in Saskatoon, along with other centers across the country, I know we're involved in enrolling patients in this study, and hopefully we'll also have results for this soon, because then patients would be able to obtain access. I think it's also important to note that these agents are also being studied in the early stage setting as well. So we're moving these very beneficial agents into trying to treat stage 1 and stage 2 disease, once again, to optimize cure. One entity I also wanted to touch on is brain metastases. We know that brain metastases is an area of very high comorbidity and poor outcomes for patients. And we know that certain subtypes of breast cancer, triple negative breast cancer, HER2 positive breast cancer, have a higher risk of brain metastases comparatively to hormone receptor positive. And I think it's important to also recognize that when we're looking at some of the clinical trials these days, they are starting to include more and more patients with active or stable brain metastases. Historically, these patients were often excluded from clinical trials. And so now we're starting to see that eligibility criteria are now allowing more and more patients to be enrolled and to include that as a criteria for eligibility. And I think it's very important, because now we're also starting to see, you know, benefit and efficacy for some of these agents that I described, for example, the antibody drug conjugates, in terms of their efficacy and outcomes for these patients, because it may minimize the use maybe for whole brain radiation, which can also lead to adverse events and side effects. I think it's also important to recognize that there are some local studies also being conducted across Canada, where they're also looking at screening for brain metastasis and looking at enrolling patients with early stage breast cancer and initially screening them with MRIs or CT heads at the time of diagnosis. I also just want to highlight that recently myself and other colleagues, part of the REAL Alliance, so it's a group of Canadian physicians across the country in collaboration with Breast Cancer Canada, and we recently published an article on directing the treatment of HER2 positive breast cancer, and really trying to highlight sort of what is available and accessible, and what our strong recommendations are for therapy for these patients. And there is a section in this paper that also highlights some of the treatment as well as imaging for patients with CNS disease in terms of when best to image patients. Is it at the time, of diagnosis? Is it at the time of symptom onset? And when do we sequence therapy? When do we hold the agents if they're receiving antibody drug conjugates? How do we prevent toxicity such as radionecrosis to the brain? And what are some of the recommendations? And I think, it highlights the fact that some of this area, there's very limited to no data when it comes to some of the management of CNS disease. And I think it's important to recognize that, more studies and more trials are really required for us to come up with stronger recommendations. So a lot of this may be expert opinion. Having said that, recently at ESMO this year, the European conference, a study looking at patients with brain metastasis was also presented, and this was the Destiny Breast 12. Once again, looking at trastuzumab deruxtecan, and essentially there were two cohorts that were, single arm, simply looking at patients with baseline brain metastases that were either stable, so previously treated, or active, meaning that they were untreated or previously treated and progressing, or no baseline brain metastasis at diagnosis. And these patients were HER2 positive metastatic patients who've received prior therapy in the metastatic setting, and they were received single arm receiving trastuzumab deruxtecan. And really, you saw benefits in both of these cohorts with receiving these agents. And we're also seeing a lot of studies where they've compiled some of the previous studies that I presented on in terms of looking at outcomes in patients in those studies who had brain metastases and sort of what the efficacy has been for those patients. So I think it demonstrates that there is activity in the brain when it comes to utilizing some of these antibody drug conjugates. So moving on to the final subtype of breast cancer, so metastatic triple-negative breast cancer. And as I mentioned before, this one happens in about 10% of the time, and this is when all three receptors, so the estrogen, the progesterone, as well as the HER2 receptor is also absent. One of the other updates I'll also mention is in terms of the classification remains as I described, where the estrogen and the progesterone are negative or less than 1% expression. But, we know that patients who have a low expression of estrogen and progesterone, so anything that's less than 10% expression, we know that they tend to behave fairly aggressive and very similar to triple-negative breast cancer patients. And as per our regulatory bodies that essentially govern what we're able to utilize and treat patients with, they've come up with recommendations stating that if there's low expression of estrogen or progesterone, we may opt to treat these patients as triple-negative breast cancer versus those with hormone receptor positive breast cancer. So it does offer more options for the clinician to discuss with their patients. So we've encountered this medication when I talked about it in the hormone receptor positive setting, but this is sacituzumab govitecan, and its first debut really came out in the triple-negative breast cancer setting. And I'll never forget the day when I, first heard about this agent, and also following up to that, a patient of mine who did have triple-negative breast cancer in clinic, she came to me and she showed me a printout and asked me, have you ever heard of this drug, or also called, Trodelvy, it's its name as well. And I remember, when this first was presented and we first had data on this, and, it's always exciting to hear the data, but it's always, it's always a great day when I'm actually able to access and obtain these therapies for my patient, which we were able to do for that patient who came to me that day in clinic. So sacituzumab govitecan is also an antibody drug conjugate. This one binds to a receptor called TROP2, and TROP2 is a receptor that's expressed in about 99% of the time in triple-negative breast cancer cases. So we're not often having to actually test for that receptor to see, is it present, is it not, because majority of the time it is indeed expressed. So therefore, this is why, when we're looking at triple-negative breast cancer patients and utilizing this agent, we're not looking and describing, what's their TROP2 level. Comparatively, for that other agent, trastuzumab deruxtecan, that one binds to HER2, and often we are having to recognize the HER2 expression, whether it's positive or ultra low or low. So essentially, this one binds to TROP2, and it actually delivers a payload called SN38, which is essentially a very similar compound related to another chemotherapy agent called irinotecan. And irinotecan historically has not been a chemotherapy agent that has really been utilized to treat breast cancer a lot of the times because of how it's delivered and the range of the therapeutic range, as well as it's just something that has not been utilized for the treatment of breast cancer. But now with the use of antibody drug conjugates, we're able to actually target and specifically deliver this agent for the treatment. So the side effect profile and the therapeutic range is much more desirable. So the ASCENT study is really what the first debut of sacituzumab govitecan had, looking at treating previously treated patients with metastatic triple-negative breast cancer. And when they say per ASCO CAP guidelines, this is the ASCO pathology guidelines for the definition. So this is those with an estrogen progesterone expression less than 1% and a HER2 negative entity. So patients were randomized to receive sacituzumab govitecan versus chemotherapy of treatment of physician's choice. And essentially, I think, once again, just to demonstrate these effective curves and what this translates to, overall survival is ultimately the gold landmark that we're looking at for some of these studies when it comes to benefit for these patients. And we see that the overall survival was almost double for these patients. And we know that triple-negative breast cancer is a very aggressive and challenging entity, but we see here the overall survival was 12 months versus 6.7 months for these patients. And I think I just want to also highlight that, in the Canadian landscape, we're not wanting to necessarily wait for the final overall survival data curves to be able to access and obtain medications for our patients, because that is, time is of the essence, and we want to be able to, treat our patients accordingly, especially if we have initial benefits and outcomes demonstrated on initial data readouts. And so I think what's also important to recognize that, yes, we have a lot of important clinical trials that I've reviewed so far, but I think it's also important to recognize that our regulatory bodies are also recognizing that it is important for medications to be reviewed and fast-tracked efficiently, so that we're not waiting, months, if not 1 to 2 years, to obtain access for our patients. So many of you have maybe heard of CADTH, the Canadian Drug and Technology Health Board, which would essentially review medications and give either a positive or negative review as to whether medications should be reimbursed by our provinces. They have now sort of rebranded in what's called now the Canadian Drug Association, or CDA, and they are recognizing that these medications do need to be reviewed in more of a timely manner so that we can get access for our patients. I also want to highlight, there's a ton of new medications that are coming down the pipeline, and due to time limitations, I won't be able to get into all of those. But I think it's important to recognize that there are so many new and novel antibody drug conjugates that are being developed. As I said, they're being tweaked ever so slightly so that they're able to deliver medication more effectively, maybe have have less side effects, just be a little bit more optimized. And so one of the other similar antibody drug conjugates that has also been developed is datopotamab deruxtecan, or also known as Dato-DXd. And once again, we're utilizing this agent at the moment, more so in clinical trials. So if there's a clinical trial that's open at your center, whether it's for metastatic disease or even early stage disease, patients may be eligible to receive datopotamab deruxtecan. And I think it's also important to recognize that there are subtle differences in terms of side effect profiles for these agents as well. Although I say these are chemotherapy 2.0, I think it's also important to recognize that a lot of these agents are infused intravenously, so they do require time and visits to the cancer center, blood work, monitoring for fever, infection. Often we're worried about sometimes interstitial lung disease or inflammation to the lung. This agent in particular, we're also looking out for ocular side effects. So dryness to the eyes may be something, as well as stomatitis or mouth sores as well. So very important to recognize that there are subtle nuances and differences with all of these different agents when it comes to how their mechanism of action is, how they're delivered, what their sort of the differences in the components, but also the side effect profile as well. And, this is where I think education is very important, not only for patients and allied health professionals, but for everyone involved to recognize that, there are differences between all of these agents and how to recognize and highlight them, especially if patients are showing up to their community hospitals or to the emergency departments, and other physicians who may not be immersed in the oncology world are as familiar with it. But not only are we seeing advances in terms of these antibody drug conjugates alone, but we're also starting to see a lot more studies looking at not just these agents being studied by themselves, but also in combination with other agents. So you may see studies coming down the pipeline where these antibody drug conjugates are being combined with therapies such as immunotherapy, for example. And, we're starting to see phase 1, phase 2 data where we're starting to see a little bit more benefit. So it is trying to figure out what's best. Sometimes more is not always better. And I think we're trying to figure out sort of what better biomarkers can we identify? How can we better personalize our therapies to patients? Moving on to some other advances in breast cancer, because it's not always necessarily about the drugs or the treatments that we have on hand. But going back to precision medicine, I think it's also important to recognize that testing for germline mutation, presence of germline mutation testing has also really become more prevalent in day-to-day practice. And I have a lot of patients also inquiring about ctDNA as well. So we'll touch on these two entities as well. I think it's important to recognize, what is a germline mutation versus an acquired mutation. I spoke previously about that AKT alteration pathway, and I think it's important to recognize that an acquired mutation is something that is not inherited. It's not something that you receive from your parents or can pass on to your children. It's something that sort of develops spontaneously in the cells in the body that don't pass on to your offspring. Whereas germline mutations are hereditary mutations. These are mutations that are inherited, so they are passed on from your parents and can go on to your offspring. Many of you may be familiar or have heard of the BRCA mutations. So we are aware that there's various risk factors that are involved in terms of developing breast cancer. Of course, age, gender are big factors as well. But there's also about there's about 10% of the time we can see a hereditary entity involved. And so the BRCA1 and the BRCA2 mutation can increase one's risk of breast cancer, ovarian cancer, pancreatic cancer in both men and women, as well as prostate cancer. So I think it's important to recognize that it's not just breast cancer that these mutations can be involved in, because when we're testing for these agents in an individual, and you ask if they have any siblings or any children, they may only mention, their daughters, but it's important to also recognize that these can be passed on, to their sons as well, and can affect other cancers as well, like prostate cancer. So as mentioned, about 10% of the time we can see cancer being affiliated with these germline mutations. And often we see that a higher proportion, so, about 10% of the time, 17% of the time in triple negative breast cancer, we see germline BRCA mutations, whereas a very smaller percentage of the time, only 7%, do we see it in hormone receptor positive breast cancer. So although triple negative breast cancer is a smaller population, they have a higher prevalence of germline mutations. So something important to recognize. So one thing that has, changed recently across the country and globally, and something I'm very proud to be involved with, especially here in Saskatchewan, and is essentially the way how patients are offered genetic testing. And I think it's important to recognize that ideally we test all our patients for these germline mutations, but the reality is we are in a public healthcare system, and we need to be judicious when it comes to testing, because it costs money at the end of the day. So the traditional way how patients would get tested for germline mutation would be patients would be first referred to the genetic counselors. They would get pre-test counseling by the genetics department. Then they would go for blood work, and then the results would be disclosed by the genetic counselors. Now, due to resources, time, etc., this could often take months, if not years, to get these results back. What's now come into effect, and I do think this is a very positive advancement for breast cancer, is what's called mainstream testing, whereby we actually bypass that initial consultation with the genetic counselor, and the oncologist or the surgeon can actually order the genetic testing for that patient. The patient can go for blood work, and then the results are disclosed by the physician. And if they are indeed positive results, then the genetic counselor will discuss the details with them. So this can really cut down the time of getting these results by, from years down to maybe about 2 to 4 months. So across the country, this should now become, sort of our standard of care therapy. And I've been involved with getting our province of Saskatchewan up to speed, where patients are able to get mainstream testing done. And the reason why it's important for us to get this testing and to know this information. I always say information is powerful, and it's important for us to know if you have a BRCA1, 2 mutation, or even a variance of undetermined significance, where we can test you again in the future, because essentially it can impact treatment options. So for early stage breast cancer patients, this may impact the type of surgery they get, as well as the adjuvant therapy I may offer them. In the advanced setting, it may also affect maybe the combination cocktail of chemotherapy I may provide. We know that some chemotherapy classes, such as carboplatin, may be more effective in patients who have a BRCA mutation. Maybe I might be able to utilize more targeted agents, such as PARP inhibitors, for patients who have a BRCA mutation. So it does impact therapy options for patients. And on top of that, it also will impact their family members. So, it allows for their family members to also get tested, which can, help prevent their risk of cancer development. So I think this is something that a lot of us in the breast cancer world are very well aware of. The guidelines are also being modified and changing as we speak. When we look at the ESMO guidelines, the recommendation is that all breast cancer patients 50 years and younger should be tested. All triple negative breast cancer patients should be tested, male breast cancer patients, etc. For the ASCO guidelines, they are now saying all breast cancer patients should be tested. So, ideally, when you see a patient, sitting in front of you in the clinic, it'd be ideal to have sort of all of this information up front. What is their what is their subtype of breast cancer? Is it hormone receptor positive? Is it HER2 positive? Is it triple negative? If it's hormone receptor positive, what are their AKT mutation status? Because that will help with determining, therapy options. And for all of these patients, what's their germline mutation status? Because will that impact their treatment as well as their family members? So, maybe that day will come where we'll have all of the information all at once to help better deliver, more personalized medicine for our patients. Moving on to ctDNA. ctDNA is also known as circulating tumor DNA. And I think what's important to recognize is that we cannot detect breast cancer on routine blood work. I had a patient the other day where they had blood work done, routinely in hospital, just a regular CBC, looking at their kidney function, and everything was good. But then they went on to having, their routine mammogram, and then, of course, a suspicious lesion was identified, and they were surprised because they said, "Well, I had a completely normal blood work. Why was this not picked up on my blood work?" And I think it's important to recognize that solid tumors like breast cancer do not show abnormalities in, your regular CBC. So often we see abnormalities when we're dealing with blood disorders or blood cancers. But, ctDNA is essentially looking at circulating tumor DNA. So where they're actually specifically looking at DNA strands that are coming from the tumor cells circulating in the blood. And, there's a lot of applications that are being utilized for this in cancer, where we're looking at diagnosing it at the early stage, predicting response to therapy. So patients who are receiving therapy in the early stage setting might get tested for ctDNA to see, what was their response to maybe neoadjuvant therapy. And then in the advanced setting, monitoring ctDNA levels, just as one may receive scans every 3 months or so, but monitoring that routinely every couple of months to see sort of, is that rising, is it stable, and to monitor for disease progression. So a lot of this work in the world of ctDNA has been performed in clinical trials, and as of right now, it's not prime time in Canada, but speaking to my colleagues across the country, especially in Vancouver and Toronto, there are clinical trials. There's the precision oncology area in the POG in Vancouver, for example. So there are entities where they're looking at making it more mainstream and applicable for patients. So it is definitely coming, and it's once again it becomes what is available, what are we able to do, how can we validate it, and how can we support our lab and funding mechanisms. So I do foresee that ctDNA will become a mainstay in terms of monitoring patients with metastatic breast cancer. How are they responding to their therapies? How can we optimize their options in the future? But as of right now, this is not something that we're able to routinely access for patients. But I think it is important that to understand that it is being studied, and I think will be in prime time very soon. I'm going to just end off on my final slide here. I spoke a lot about some of the novel agents that have, demonstrated great outcomes for patients. Some of the precision medicine and testing with next generation sequencing. But I think it's also important to recognize that supportive care and integrative care is also a huge component of cancer care in general. Today's talk was focusing on advancements in metastatic breast cancer, which is a palliative entity where we are trying to control the disease, manage symptoms, and really optimize patients' quality of life. And I think it's important to recognize that this is becoming more and more recognized, where we need to involve our palliative care team to make sure that patients are getting appropriate care sooner rather than later. And in fact, has been demonstrated that patients' outcomes can often be far more beneficial if we involve palliative care earlier than later, and can also sometimes be more impressive rather than some of the agents that we're utilizing. And in fact, at ASCO, one of the late-breaking abstracts presented was also showing sort of the benefits of even televideo care for palliative care. I'll also make mention that some of these novel agents I described can also cause many different side effects, and one of them being nausea. And with the MASC guidelines, or the Multinational Association of Supportive Care in Cancer, they've also recently updated their guidelines to ensure that optimal antiemetics are being provided for some of these antibody drug conjugates, so that patients are not suffering with cycle 1 and not wanting to continue with further therapy that we know is very beneficial. So I think it's important to recognize that it's not just simply the get the drug, access the drug, give the drug, but everything else that comes along with it, and ensuring that patients are connected to the appropriate care teams, palliative care, social work, etc., but also having supportive medications on board and accessible and also covered. So I think I'm just a few minutes before the top of the hour, so I'm going to pause there and end my presentation. So I really thank you all for joining and listening in. I hope this was helpful as well as resourceful, gives you a glimmer into the world of what I see in terms of metastatic breast cancer. And I think it's going to be exciting to see all of the new data that's coming our way. Many of you also may be familiar that the San Antonio Breast Cancer Symposium is one of the other big conferences, is coming up here in about 2 weeks in Texas. So I'm sure we'll have much more data to learn from, and much more novel therapies that will be coming our way. So thank you, everyone, and I'll open the floor up for questions. And I think Kathy's also going to help me field the questions.
I just want to thank you. There's so much to unpack here, and I really think this was an amazing presentation in terms of what's out there, which is very hopeful, and we just like the fact that things are progressing and moving on. And it was just wonderful to see it all, and how you unpacked it was very, very easy to follow. I just have quick notes that I've been taking in terms of continuing research. Do you think that we're in a good place? Do you think that research has stopped a little bit? Are you concerned that we may hit roadblocks in terms of research funding, etc.?
I think research will never end. I think research, we are at the end of the day, we are scientists. We have questions. We want to try and solve the questions. And so research is a big part of what we do. And whether it's investigator driven, so whether it's like, myself wanting to initiate and collaborate with others across the country, or it's industry sponsored. And so, there are a lot of means in terms of getting funding and being involved. I don't think that research is going to stop anytime soon. In fact, I'm actually finding that we're getting more and more involvement with research, which is important. Ideally, I would love for all of my patients to be involved in a clinical trial in some capacity. I think it's a great opportunity. It only helps sort of shape our landscape. We wouldn't be where we are today. I wouldn't be able to offer some of the therapies I have today without research, right? And so I'm always in favor of collaboration. Even in our center, I've been able to bring studies to our center, with where I'm collaborating with other colleagues in Alberta or Ontario, etc. So I definitely think it's here, and it's a matter of how we get it on board. And I think funding is very key, because it not only helps support the center, but we may be able to help support patients receiving these therapies, right? So whether it's transportation, etc.
And how do you find the access to these, medications, especially in the metastatic setting, where it's mostly, specialized for certain population, right? Do you find that the access is good enough across our country? I know United States is different, but we have a different healthcare system.
We have a very different healthcare system. So just to kind of break it down, what happens is, first FDA in the States will say, yes, this drug is approved. And then Health Canada often says, yes, it's approved for this. You can use it for this indication. It often happens usually about 6 months after FDA says yes. Then after Health Canada says, gives a notice of compliance that says, yes, it's safe to use this drug, anyone could pay out of pocket for it. Right. But then what happens is it then goes to the CDA, or the Canadian Drug Association, where they actually do health economic analysis, really dissect the data, discuss it with experts in terms of should we be funding and utilizing this agent in the Canadian health system. While that is undergoing deliberation, which can take, as I said, anywhere from 3 months, 6 months, 1 to 2 years, depending on the sequence of events. While that is happening, often pharmaceutical companies may offer support programs where they are able to offer that medication for individuals who are eligible in Canada. And it's often they may provide it at 100%, they cover it, or they work with your insurance company, or there might be a copay involved. So while they're waiting for CDA to deliberate, there'll be maybe an access program available. So that AKT drug I mentioned, that is under an access program as we speak. So the company is helping us pay for the genetic testing, and then the company will pay for the drug if they are eligible, while CDA is going through deliberation. If CDA gives a positive recommendation and says, yes, our healthcare system should fund this and patients should receive it, then the provinces essentially fund and pay for the medication. So there's a long process for the lifespan of a drug to get funded and be seen in the clinic. Now, it's not optimal. There's always room for improvement, especially when I'm talking about timelines. But I think especially specialists across the country are always sort of have the finger on the button, knowing, what's happening, where are things with the drugs, what can we access for medication. So that's why it's important for us to stay up to date and know what's going on so that we can access appropriate medications for patients.
Thank you. So I have a quick question around the ctDNA testing. I would imagine that would be much more beneficial in terms of cost, like to have a blood test versus biopsies and mammograms to continue monitoring. So do you see this being implemented very quickly once these studies are done, because it would be beneficial both for the patient and the healthcare system?
Absolutely. And I think it depends on it will be implemented in particular circumstances. So right now, as we speak, actually, that AKT alteration is done on the biopsy specimen, right? So, but we are looking at is the ctDNA, is that validated? Is it equal to a biopsy? And can we do that instead over a biopsy, because it would spare, the resources, the patient having to go for a biopsy? Can we actually do it for that setting? So yes, I think from a cost perspective, it may be less, but I think there'd be certain indications where we might see it rolled out sooner versus like all comers, right? So I think there'll be specific indications for ctDNA, and I do foresee it happening very soon because, as I mentioned, it is being done in clinical trials. So if you are enrolled in a clinical trial at your center, you probably may be having ctDNA collected as we speak. And I know my colleagues in Vancouver are also working at getting their program up and running. So they might be one of the first in the country too.
Okay, that's fantastic. And in all the treatments that you're discussing, I know I don't think all would apply, but in terms of using them as first line before people become metastatic, if they do become metastatic, how many drugs would you say that could be used in early stages?
So of the drugs that I mentioned on today's talk, for example, like sacituzumab govitecan, there's studies that are being, right now, unless you're on a clinical trial, it's not funded for in the early stage setting. So sacituzumab govitecan, trastuzumab deruxtecan, even Dato-DXd, they are all being studied in the early stage setting. But as of right now, they're not part of standard of care. So outside of a clinical trial, I would not be able to use any of these agents for early stage patients.
Okay. And how would you determine, how would we determine, I mean, the collective, healthcare professionals, how would we determine that they would be beneficial so that we could do prevention even more?
Absolutely. So right now, until the data has been presented and until we have information on that, will we actually be able, it will probably go through the same sequence of events that I described. So once the data has been presented, for example, like the Destiny-09 is looking at T-DXd in the first line metastatic setting. If that truly shows to be beneficial, then it'll go through that journey of the drug through our Canadian healthcare system. I think it's also, anytime you're wondering, what is beneficial to me? What do I have access for myself? Where, and everyone is on this webinar is, from coming from different areas across the country, right? So I may have a clinical trial that's open, but Alberta may not, or Ontario may have a trial open, et cetera. So it's always important to talk with your healthcare provider, what is available at my center. And if there may be a clinical trial that you may be eligible for at another center, could you potentially, seek enrollment there? Keeping in mind that this is where funding comes into consideration, where let's say I have a patient of mine who may be eligible for a trial in Edmonton. I often try and see if the sponsor might be able to fund for transportation, accommodation, et cetera, right? So there is a way to collaborate to get patients enrolled in clinical trials and to access these certain drugs. Clinicaltrials.gov is a great way to kind of research and kind of Google, what you're looking for and what studies may be open and where as well.
And one last thing that I was making note of in terms of so you broke it down into triple negative, HER2 positive, and HR positive. How many other discoveries do you think that we will be seeing in terms of tumor biologies? And is the medical community seeing it already and just not understanding it and applying anything to it?
Yeah, I would have to say it's the latter. We understand that under triple negative breast cancer, for example, there are several other subtypes within that entity under that umbrella. So there's a basal subtype, metaplastic subtype, for example. But we don't we're not tailoring our therapies based on those minute individual subtypes. Neither are we necessarily testing for that, because that's a different genomic testing profile either. Same thing when it comes to hormone receptor positive. There's also what we call luminal A, luminal B. Those are some of the genomic profiles as well. We sort of test for it in the early stage setting to see if patients require chemotherapy or not. Often it's those who come back as being almost like a luminal B are at higher risk and require chemotherapy. But in the metastatic setting, it's not the case. So we are aware that there are, as I said, there's a huge umbrella for breast cancer, and not all breast cancer behaves the same. Right. And so we understand that there are different subtypes. They all behave a little bit different. But as of right now, we're not, majority of the time, we're not tailoring our therapies based on those subtypes.
Thank you. And one last note, is there more imaging now involved in patients because of these extra lines of treatment? How harmful or not are all these imagings?
Yeah, that's a very good question. So similar to the paper that the Real Alliance published, we also published another paper on staging and imaging. It does speak more to early stage breast cancer in terms of staging. But I would say that, we are becoming more, imaging is becoming ubiquitous. Patients are at baseline are receiving CT scans to ensure there's, no distant spread, bone scans in the early stage setting. Some patients may also receive PET scans depending on sort of the details of their cancer, or even, where they may be located. When it comes to the risk of, radiation exposure and, secondary cancers, that is a very minimal and very, low risk involved. And especially when we're already dealing with metastatic disease, that risk is extremely low as well. But I think we are recognizing, in the metastatic phase, majority of patients are getting imaging with CT scans, every 3 months to assess disease status and response to therapy. We're also utilizing MRI imaging, especially for the brain, for screening or monitoring for brain metastases. PET scans are also being utilized as well. But once again, PET scans may be very limited based on accessibility. There may be only 1 or 2 in the province you are situated in. But yes, imaging is a huge part of our treatment modalities. In fact, I described, in the metastatic setting, every 3 months, there are clinical trials that I'm involved in, or even looking at starting up at our center, where the sponsors and the study trial is looking at scanning patients every 8 weeks,
Mm.
which doesn't sound too bad, but already our healthcare system is
Yes.
already burdened, and patients are feeling that in terms of the delays and the wait times, and to be scanning patients every 8 weeks is going to be very, very challenging. So
Yeah, and the questions always are because I think of both, right? The patients and the burden on the healthcare system. Thank you. Thank you for answering those. I'm now going to read some of the questions that came into
yes,
us.
yes.
I'll start with this one is wondering why luminal B subtype is treated the same as luminal A, even though they are pathologically different.
Yeah, and that's a very good question. Just as I described, we know that there's those subtypes that are present. Luminal, when we're looking at early stage breast cancer, they may be treated slightly different. As I said, we might be able to do Oncotype DX recurrent score testing. So that's another genomic profile that we look at to see if they're high risk or not, and if they require chemotherapy or not. And those who often come back high risk are often the luminal B. So they often do receive a slightly different treatment modality. In the metastatic setting, and I didn't speak to this part today, but there are studies looking at your estrogen, progesterone low expressors, your grade 3, and looking at the use of immunotherapy in that setting. So as I mentioned, there are some minute differences where we recognize that the estrogen, progesterone, those who are low, less than 10%, often we may treat them more as a triple negative breast cancer. And there are some studies looking at integrating immunotherapy for those patients. But you are correct. There's the major pathway and algorithm is very similar for those patients.
The next question, a person with triple positive disease being treated with Taxol, Perjeta, and Herceptin asks have there been any developments treating this? Perhaps you can also speak a bit more broadly to the approach to treating triple positive disease.
Yep, and I think that's a good question. So when we're looking at triple positive disease, it would fall under a HER2 positive disease and those that are hormone receptor positive. So essentially, they receive the same treatment as all patients who are HER2 positive, but they have the addition of targeting the hormone receptor, so endocrine therapy. And so often the endocrine therapy is given mostly in the first line setting, and then thereafter, and I don't know exactly what the rationale is, but thereafter the endocrine therapy is actually sort of dropped, and really just they carry on with the HER2 directed therapy. But in terms of advancements for the HER2 positive setting, as I mentioned, the first line, the standard of care as of right now still remains chemotherapy with pertuzumab or Perjeta and trastuzumab. That is kind of our first line setting. And then patients may go on to receive trastuzumab deruxtecan in the second line setting. As mentioned, the Destiny Breast 09 is looking at trastuzumab deruxtecan in the first line setting, and they have different comparator arms in that study. Once we have readout and data from that, that may change the landscape in terms of our first line setting options. So as of right now, the Perjeta trastuzumab with chemotherapy remains our first line setting, and then goes on to trastuzumab deruxtecan. Same thing in terms of the algorithm, treatment options thereafter. It's tailored to the patient and what their disease looks like.
Thank you. Are there any links between HER2 positive and pregnant breastfeeding women? I was diagnosed with de novo postpartum, and I kept meeting other women diagnosed with the same subtype during this stage of life. I guess they're younger women, and a lot of them, I agree. I come across individuals who are postpartum, maybe a year or two, and then all of a sudden they develop. And when they do, a lot of the times, I don't have numbers, but they're triple negative.
Yeah, and that's a very valid question. In my practice, I would say that I see a lot of younger women with breast cancer, both early stage as well as metastatic, under the age of 50. I have seen women who've been diagnosed during their pregnancy as well as shortly after and while breastfeeding. And so I would say, yes, triple negative breast cancer may be one that I actually see more commonly. I have seen HER2 positive as well as hormone receptor positive. So I don't think there's necessarily one subtype that may be more prevalent or maybe might be more linked to pregnancy or breastfeeding. I just think it's young women in general, and I don't have the answers as to why we are seeing more and more younger women. I do have my scientific hat on, and I think my guesses would be, could it be environmental factors that we're exposed to that's very different to 20, 30 years ago? Could it be the amount of microplastics that we're exposed to, environmental changes, food, diet, lifestyle? I think there's a lot of components there, because we're seeing a lot more younger women who are not necessarily obese. They don't have any germline hereditary reason. They're non-smokers. There's really no good explanation, and I can't link pregnancy or breastfeeding to one particular subtype. So I've seen a smattering across the board, but as far as I know, that I haven't seen any particular link.
It's a valid point, because at the beginning they say stop smoking, right? Breast cancer was linked to smokers. A lot of people don't smoke anymore, and women do not smoke anymore the way they used to. But we're still seeing numbers that are relatively the same, even when we were, historically smoking, right? And the other thing I would ask that you mentioned is environmental. Are there studies being done? Could we differentiate when we diagnose patients that it is in fact environmental because of some substance that we're breathing, eating, etc.?
I that would be a very interesting study. I think it'd be a very difficult study. Sometimes lifestyle, like when it comes to nutrition, studies are very challenging to conduct, because you can't control for all of the elements. I know that there were some studies presented at ESMO and ASCO this year, looking more so at obesity and BMI, so those type of lifestyle factors, as well as integrating activity. So patients who, and it's also been demonstrated, and I know they conducted a study in Vancouver looking at patients who were enrolled in exercise programs, ended up having better outcomes, right? So I think environmental factors, unless they're able to somehow measure or detect that, yes, microplastics might have a element, in terms of affecting our health. How can we actually measure it? How can we control for it? And how can we, study it? Then maybe we'll see it. But going back to your point on smoking as well, I think it's also important to recognize alcohol as a risk factor as well.
Sure.
2 years ago, we'd always hear mixed messages, maybe, 1 glass a week, or I think for females, it was, 4 to 5 glasses a week was kind of the recommended maximum amount. And then the guidelines came out, 2 years ago, saying no alcohol whatsoever, because any alcohol at all increases your risk of cancer, right? So I think there's a lot of elements involved. And we could talk for hours about that, because it's fascinating, right? Because as I said, I'm seeing a lot more younger women, and even Ontario just published the cost of breast cancer care per age on, and you can see, you can see the numbers for those, 40 and younger.
So, it comes to mind that we used to think about smoking, but food was better. And now we're not smoking, but food isn't as good because of all the additives, preservatives. So, and that balance hasn't really tipped, because we replace something with something else. So anyway, food for thought. I'm
No
going to
pun.
continue. I'm going to continue with our questions. I'd like to give an
Yeah.
opportunity to these questions that came in. So one of them says, can you tell me what percentage of early breast cancer metastasizes? I've heard 30%, and that seems high to me.
Yeah, it depends on the subtype of cancer, right? So when we're looking at hormone receptor positive breast cancer, and especially the early stage, they probably have a lower risk of metastasizing, and often we see more delayed recurrences. So these patients may relapse in, maybe 5-10 years. We see more like the 10-year recurrences, right? So it can be upwards of 30% for those patients, but I would say it's probably a little bit lower. HER2 positive as well as triple negative breast cancer, they have also higher risk of recurrence and metastases as well. So I would say 30% is an average. So it is high, and that's why you'll see that for early stage breast cancer patients, I'm often describing a very lengthy and involved journey for them. Their treatment can be, upwards of 1 to 2 years. And now we're seeing even 3 to 5 years of therapy. This is not just hormone blocking therapy. This is like targeted agents and, other therapies involved to try and protect and prevent metastases from happening. So 30% is high. We are doing better, but I think I think this is broad terms. So unless you're looking at the specifics for that individual, like what subtype do they have? What is their grade? What is the stage? Is there lymph nodes involved? What is their estrogen level of expression? Those type of things. There's all these little nuances. And to add to that, we try to predict and try and provide numbers best possible for our patients. But sometimes it can be very challenging. But there are some, validation tools that have been developed and are being validated. So for example, there's one assay called the HER2-DX assay score, where patients with early stage HER2 positive breast cancer, essentially you can input the details and find out what is their chance of responding to neoadjuvant therapy, what is their chance of recurrence. But that tool is not, once again, I sound like just repeating myself over and over again. But once again, that's not available in Canada. It's not validated. So until we have more, details on hand, is it something that we can incorporate into practice? So.
And I'm thinking the HR positive, which is the larger number, and they do recur later on. I guess the Lumina A and B come into play, correct?
100%, absolutely. Luminal A, they have probably the lowest chance of recurrence. And those, majority of the time, those are the ones who are, likely going to be cured. The luminal B, those are probably the ones who are at higher risk, going to require chemotherapy. They might require the adjuvant CDK4/6 inhibitors as well. And so they might have a higher risk of relapse as well. So these are all these minor nuances between all of the breast cancer cases. But I think generic terms, yes, the risk of recurrence can be high. Every patient undergoes means to try and reduce that risk.
Great. So what is PARP I? I think that's what's written.
Yeah. So PARP inhibitors is essentially if you have it's an oral medication. Once again, it's a targeted agent. We utilize it both for breast cancer as well as ovarian cancer, as well a similar agent for prostate cancer. And essentially how it works is if you have a BRCA mutation, essentially there's another mutation that also helps sort of the PARP mutation that kind of help drive the cancer cells to grow. So it's all coming down to how can we stop this cancer cell from growing and dividing. So a PARP inhibitor is a specific medication that essentially is utilized in BRCA mutation patients to try and stop the cell from growing and dividing. And there's certain indications where it's been studied for those who have the germline mutation in the early stage as well as the advanced stage. And there's only certain settings where we're actually able to access these medications.
I'm going to ask one, to me, it's curious to me, is the term oligometastatic breast cancer recognized in Canada? It seems to be spoken of more in the United States. If it is, how is it treated for curative intent versus a true stage 4 breast cancer?
Yeah. Oh no, oligometastatic is for sure recognized in Canada. In fact, the definition is something that can be argued about in terms of what does oligometastatic mean. It really pertains to the number of metastatic sites. So one may have metastatic disease, but oligometastatic often refers to usually 4 or 5 sites of disease or less. So let's say it's spread to the liver, and there's only 1 or maybe 2 spots in the liver. That would be oligometastatic disease. Or you had it in the breast and it had just 1 spot that spread to the brain, even though it's CNS metastasis, that would be oligometastatic disease. So yes, it is very well recognized. And these are very individual cases where it would be discussed at tumor board rounds, where you would have sort of a consensus in terms of therapy and options. And this is where it might be individualized in terms of, do we try and treat with curative intent and maybe try and target that one area and provide ablation or what have you? Or is it something where, we actually have very, very effective systemic therapy options and we treat it more metastatic? So there's it's a very gray area. I would say, in my practice, these are patients that you would discuss at tumor board rounds. I have some patients who are undergoing, more of a curative intent strategy because it is amenable to local or targeted therapy. And then there's other patients where we might not be able to. So it's very individualized, but yes, oligometastatic is for sure recognized.
So I'm going to give you one last question because I think it's important if you give us a small, input. Reading clinical trial results can be confusing. Can you offer 1 or 2 tips of understanding clinical trial results?
Yes,
I know it's a big question because that's a big topic in itself. So
yes.
take it
Yeah,
away.
and I'm not a statistician. I'm not a statistician. These things are very challenging, and I think it's always hard to relay it for the general population to understand. So the more and more you kind of get accustomed to seeing it, reading about it, and recognizing some of the common terms we utilize, I think bottom line is when we're looking at cancer studies, some of the main target endpoints we look at are progression-free survival and overall survival. So progression-free survival means the time it takes from the time of diagnosis to when the disease progresses. And that might be 1 duration. And then the progression-free survival 2 might be from, the time of the first progression to the next progression. So that's progression-free survival. So the time it takes for the disease to progress. Overall survival, as I described, is the gold standard. How the time from either the time of diagnosis, time of starting treatment, the time the patient dies, whether it's related to cancer or some other entity. Those are the main outcomes we look for. And we're always looking for numerical, but also statistical differences. When you're looking at stats, some of the key numbers we're looking at is a p-value that's significant. So something often that's less than 0.05. I will say a lot of the studies that are being presented at congresses and meetings, they will have their slides available for those who register, but they also provide slides in layman's terms, so for everyone to understand. So I would encourage people to try and access those resources if possible. So if you are attending or register for San Antonio, for example, or register for ASCO, they do have it available in layman's terms. But ultimately, it really should hopefully be your oncologist who is, describing the best possible options that are available and what's also best for that patient in front of them as well. The numbers can be very confusing, so I wouldn't get too caught up on it. But the more and more you read and kind of become familiar with it, it's key. Bottom line is we like seeing those curves, those Kaplan-Meier curves. Yeah. We like to see them separate, right? That Destiny Breast 03 study, that was a one that shows, someone described it as you can drive a truck between those curves, right? We're nerds. We're big nerds at heart, right? And, when you see curves like that, it always makes us very happy because you see, oh my goodness, there is a benefit for this versus standard of care, comparator arm. That's what we're looking for. When you see those curves coming close together, they're not crossing, we're not very happy about that, right? So I think that's the bottom line. So.
And very quickly, I know we're running out of time, but these are too important. What about when you're indicating extended time of survival because of the study? Sometimes they say 12 months, 6 months. Is it truly 6 months? I know it's not, but is that how can somebody who doesn't really work in that area understand that? Is it more? Is it a lot more, or is it just definitely 6 months? Because it
Yeah.
is really 6 months if we're, talking 6 months.
I think, yeah, it's always hard to, because you don't want to give false hope, but you don't also want to like just give a number where someone's going to just be focused on that number. So you
Right.
often describe it as it will improve and extend your life, but your quality of life ultimately is the goal. And then I think it's also important to recognize that your oncologist should be very open and honest when that time is getting short, or when, there's no further treatment options and we need to really look more at best supportive care, right? So I often will describe it as, it is going to extend life. And I often describe it, in a matter of months. It could be longer, but it could be shorter, right? So I think I would take everything with a grain of salt for sure. I will answer that one question in the chat box. Mainstream
Yes.
testing should be available in Alberta. They were one of the first provinces to start testing. So I know for sure Alberta, BC, Ontario, for sure they have mainstream testing available.
And lastly, before I conclude, how do you recommend that patients research all the information you just donated to us and other information, especially in the metastatic world, to streamline it for the optimum benefit for themselves to understand? How do you pick and choose what to retain for yourself and make it more personalized to you?
Yeah, I think that's a great question, because there's a lot of things on the internet, so you can go down a rabbit hole. So first and foremost, have a conversation with your oncologist to know your details, your treatment. They should also be able to provide you resources. I often go to BC Cancer website is a great place for resources. So you can go on there. You can even search for the drug that I spoke about, and you can see their monographs or patient handouts on there. Cancer Care Ontario as well. Those are two of our big bodies in Canada. Canadian Drug Agency, so CDA, they have all the algorithms and recommendations on there as well. So those are really valid and good resources and tools to go to. Webinars like this are going to be great. So that I understand this will be recorded, so you can go back and rewatch it. There's other advocacy groups across the country as well, Breast Cancer Canada, for example. So there's a lot of online tools and resources to go to. But always when you're going online, take it with a grain of salt in terms of what you're reading, what you're looking at. Talk to your healthcare team, because they will know all the nuances and the details and hopefully direct you in the right way. So.
Thank you. Now this is truly it. That concludes our time for today's session. Thank you everyone for your questions and for joining us to learn about recent advancement in treatments, care, and research for metastatic breast cancer. Thank you very much, Dr. Manna. It was fantastic. This was a great episode, for being here with us today. Thank you again to our sponsors, Novartis, Pfizer, Gilead, AstraZeneca, Merck, Daiichi Sankyo. And following this session, you will get a link to complete a survey to provide feedback on this session. Please consider leaving feedback on this session, because leaving feedback, it helps us to improve future sessions for attendees like yourself. And if you haven't already done so, there is still time to register for next week's webinar, questions and expert session on side effect management for systemic therapies. In this session, a medical oncologist and pharmacist in oncology will answer your questions about managing treatment side effects for breast cancer. Use the QR code on the screen to register. Have a wonderful afternoon. Thank you, everyone, and have a great day. Thank you again, Dr. Manna.
Perfect. Thank you, everyone. Thank you, Kathy.